we've invited Dr. Ashesh Pabbies to present a story about prostate cancer in his family medical practice. And if we're going to make any significant headway with this disease, it is actually through the interaction between the patient, the man that is, and his family doctor. That's the first line of defense, the first line of offense with this disease. Dr. Pabbies got his medical degree from the Flinders School of Medicine in Adelaide, Australia. He took his residency in family medicine at University of Calgary, and he's the founder of and CEO of the Foothills Medical Clinic, right across from the Foothills Hospital. So, ladies and gentlemen, please do welcome Dr. Pabbies.
Great. Thank you for having me. I'm hoping you guys will find this informative. There's probably going to be some topics that you guys have already discussed with other healthcare providers. Can anyone hear me? Everyone hear me? Okay. Sure. Can I raise that up? Is that better? Okay. So, ooh. Should I just clink something here? So, I'm going to just start by saying who I am. I'm Ashesh Pabbies, and I'm a specialist in family medicine. I am the founder of the Foothills Medical Clinic, which operates 2 clinics within the Foothills professional building. Our clinic is focused on preventative medicine, early screening, as well as chronic disease management. So I think this is going to be a good talk. Just to start, I'm going to say, as a disclaimer, I haven't received any form of compensation for this presentation from any pharmaceutical companies or anything of that nature. Ron did promise to talk to my wife about buying a muscle car, but that's about it. Okay, so topics for today. I'm going to define prostate cancer, identify the individuals who are at risk of prostate cancer. We're going to talk about early screening, staging and the Gleason scores, treatments, the role of the family physician in monitoring disease response, role of the family physician in managing adverse effects, as well as the role of complementary and alternative therapies. We're only going to spend a very brief amount of time on that, and a role of the annual physical exam, which for me is one of the most important features of family medicine. So, to start, let's define what prostate cancer is. It's an adenocarcinoma, so it involves the semen-secreting glands of the prostate. Adeno means glands, carcinoma, cancer. It's a cancer of the glands. It is the most common cancer among men in Canada and second leading cause of cancer death among men in the US. 1 in 7 Albertan males will develop prostate cancer during their lifetime. In the US, they estimated that 233,000 new cases of prostate cancer will be diagnosed this year, of which we'll see 29,500 deaths. So it is common, but it is incredibly treatable as well. Just wanted to also say that if you guys have any questions at any point in time, or there's something that you need clarification on, please interrupt me at all times, okay? So who is at risk? Age is probably the strongest predictor of risk factor, okay? It has prostate cancer has a very strong relationship between age and diagnosis. According to the Albertan guidelines, it is advised that anybody above the age of 50 be screened for prostate cancer. However, periodic testing does occur in low-risk men under the age of 50 in certain family practices. This is not, we're not talking about people with symptoms, this is just routine screening. Family history. Any individual with a first-degree relative, so being a father or a brother, is considered a positive family history with prostate cancer, and they have to have had it before the age of 65. The risk also increases if you have more than one member who's had prostate cancer prior to the age of 65. Ethnicity. So prostate cancer is more common in patients with African Canadian descent. Genetics also play a huge role. So some of the gene studies that have found that the BRCA1 and the BRCA2 genes, which are commonly referred to as the breast cancer genes, individuals who carry those are at greater risk of prostate cancer. There's other genes such as the homeobox 13 gene, and I really don't know where they come up with these terms, but individuals who carry that as well as the Lynch syndrome are also at increased risk. Smoking, at time of diagnosis, does appear to increase the risk of recurrence, as well as prostate cancer mortality. And finally, lifestyle. And this is where there is some debate regarding obesity, diet, and we're going to talk about that as well as we move on. Any questions so far? Okay. So, how do we screen in Alberta? So let's spend a few minutes just talking about screening. Screening occurs by two methods. One is the PSA, the prostate-specific antigen, which is a blood test, as well as the DRE, the digital rectal exam, otherwise known as the finger in the bum test. Routine screening will start at age 50 and repeated every 1 to 2 years. That's according to the Albertan guidelines. And again, these are for asymptomatic patients. Again, periodic testing prior to the age of 50 is common practice because of older guidelines which suggested that they start at age 40. As of today, there's not a lot of evidence to recommend earlier screening in that age group. However, as a family physician, I'm more guided by my clinical judgment as well as our patients' wishes. So, what is the big controversy regarding the PSA and the DRE? Has everyone heard about the controversy regarding the PSA and the DRE? Okay, Ron has. So basically, the PSA and the DRE, they are non-specific tests, or I should say they have a lower specificity in testing than some of the other tests that are used for routine screening, such as mammograms, okay? So what does being less specific mean? It means that there's a great chance of what's called a false positive, okay? False positive is where your PSA is elevated or the physician feels something abnormal in the digital rectal exam. They send you to the urologist, you go in for the test, you get an ultrasound done, you get a biopsy done, all of which comes with inherent risk, and it all comes back as negative. Okay, everything is fine. That's considered a false positive. So that is why, you know, they certainly do recommend waiting until the age of 50 or to use strong clinical judgment before you order some of these tests or you do some of these exams. Does everybody understand that? Okay. So, very simply, if you have a positive PSA, that does not mean that you're going to have cancer. And the positive predictive value of a man greater than the age of 50 with a PSA of greater than 4 developing prostate cancer is about 31%. So, anyhow, how do we screen people for prostate cancer in the US? Same thing, PSA, DREs. However, they don't even recommend routine screening between the ages of 40 to 54. So they start their routine screening at the age of 54. And that's according to the American Urological Association. which I thought was kind of surprising because I thought that the Americans would be screening, you know, way sooner. But so that was an interesting read. They also recommend to stop screening at 70 plus years of age when, or when patient life expectancy is less than 10 years. So, everyone's had a digital rectal exam? Yep. Okay, so we don't need to talk about that. Everybody knows finger in the bum, you feel through the rectal wall against the prostate. You're feeling for a couple things. One, is it smooth? Two, is it rubbery? Three, is the contour the same on both sides? Okay. And if it's not, then you've got a positive DRE. Okay. So let's just talk quickly about symptoms of prostate cancer. So when a patient comes into the family physician's office, oftentimes the patients have absolutely zero symptoms. You do a rectal exam at the annual physical exam, and you suspect something is growing there. You send them away for a PSA, and if it comes back positive with a positive DRE, then you start moving from there. Oftentimes patients will come in and they will be complaining of what's referred to as LUTS, lower urinary tract symptoms. Urinary frequency, getting up in the middle of the night to urinate, urgency, so having a very strong urge to urinate, hesitancy, so you pull up to the urinal and it takes you a while to get going, stop and go urination, reduced stream power, so you can't carve your name in the snow anymore, blood in the urine or blood in the sperm. So what happens next? So we go ahead and refer the patient to the urologist. The urologist is going to go ahead and repeat a PSA because oftentimes it will go back down. They're also going to repeat the DRE. Sometimes. And at times they're also going to offer what's referred to as the ultrasound and a biopsy. So, everyone's had a biopsy? Yep, everybody knows how it works. I'll just go through it very quickly then. Ultrasound probe enters through the anus into the rectum. It abuts up against the prostate, and a small needle comes out and starts taking core samples from the prostate. Gleason score. So biopsies have been taken, and the pathology results come back to the family physician as well as the urologist. The pathology results are going to consist of two things. One, what is it? Is it normal tissue, just normal prostate? Or is there something growing there? And if it's growing there, is it a cancer? Then they offer what's referred to as the Gleason score. Everybody has heard that term before? Okay, great. So, I'm going to spend a couple minutes just describing what exactly the Gleason score is. It is a guide. It helps the urologist determine what the next course of action is. Whether or not the urologist is going to recommend treatment or surveillance. It's a composite score that defines the pattern of growth and degree of differentiation of the cells. Okay? So, a grade 1 is the most differentiated, which means that it is the nearest to normal prostate tissue, whereas a grade 5 is the least differentiated, meaning that it resembles nothing like normal tissue and 100% like a cancer. We're clear? So when we get a Gleason score, the first number is the most dominant pattern within inside the prostate. So if you look at the prostate as a loaf of bread, if 3/4 of that loaf of bread is a Gleason Score 3, and the remainder of that is a Gleason Score 4, that means that you have a 3 + 4. If 3/4 of that loaf of bread is a Gleason Score 3, and 1/4 of that is a Gleason Score 2, does that make sense? Yeah. Then you've got a 3 + 2, making up 5. Everybody confused? Perfect.
So you can't get a 10.
You can, but it just wouldn't make a lot of sense because it's a 5 + 5, right? So, but that's how it's scored.
So what's the highest score you can get?
I'm assuming it would be a 10. I've never seen a 10, but I'm assuming it would be a 10. Any other questions? Yep.
You mentioned stop screening at age 70.
Only if you think that life expectancy is going to be less than 10 years and if you're going to follow routine guidelines. If a patient presents with lower urinary tract symptoms above the age of 70, I'm still going to screen. I just may not consider the PSA to be as accurate. I'm definitely going to do a DRE, and if I feel something there, this patient will go to see a urologist. Again, everything is guided by clinical judgment, and that is the key. These rules, these guidelines are exactly that. They're guidelines, not laws. Any other questions?
Yeah. You're going to discuss your last bullet now.
Sorry, I was just going to take this gentleman's question first.
Just back on screening.
Yeah.
Prostate Cancer Canada recommend a baseline
Sure.
screening starting at age 40.
Yeah.
To do a PSA every 5 years until age 50, then do it annually. Do you want to comment on that?
Sure.
Advantage of a baseline?
I'll just open this one up to the group. What do you guys feel about the baseline? What do you think the baseline is there for? Okay.
Well, I would suggest that it's if you track that baseline, it's going to with a subsequent analysis, it will tell you what your trend is.
Right.
And the trend is possibly more important than the individual number.
Exactly. Yep. So that's exactly it. You're looking at a trend. And the key about a baseline is that you can go back and compare future numbers to that number. Okay? Whether it should start at 40 or whether it should start at 50, that's up to the pundits. But should you have a baseline? Absolutely. Absolutely. Would I do it any earlier than 40? Absolutely not, because the risk is very low and in many cases non-significant, and you only start seeing that exponential rise after the age of 40. But I do agree that there should be a baseline done. Whether or not you should follow it every 5 years, I don't know. I think that if you're gonna start screening at age 40, stick to your guns and do it every 1 to 2 years by getting a repeat. Otherwise, do it at 50, you got your baseline, move forward from there. And of course, if you develop symptoms in between, that throws all of that out of the picture. Good? Clear as mud? Okay. So moving on. Where are we? Okay. So we've had the biopsy, and we've got some cancer cells. Your Gleason score warrants some further investigation. So what's next? Staging. How do we stage? Usually by imaging of some sort. CTs, MRIs, PET scans, bone scans in certain cases. And there's several staging nomenclature that's available. The most used, at least, are the T&M system, so the tumor nodes metastases system, as well as in certain parts of the US as well as Canada, they still continue to use the stage system, which is probably the easiest one to understand. Simplistically, T1, T2 cancers are confined to the prostate. T3, T4s have spread or have the risk of spreading. So they'll usually sit at the end of the capsule of the prostate. So if you look at staging, the stage system, can everyone see a cursor? No one can see the... Okay, so stage 1, you can see that it's actually confined to the prostate, unilobe. Stage 2, you can see that the cancer has grown. It's taken up more of the actual prostate, but has not broken through the capsule. Stage 3, it has, and you've got localized spread. Stage 4, distant spread. Okay, and when we're talking distant spread, we're looking at pelvis, bones, lungs, liver, lymph nodes, brain. And I suppose it can disseminate to other organs as well, but it's a little bit rarer.
And you have to be able to see that on some imaging.
Yeah, and you cannot stage without having some form of objective measure. Okay?
So if it's just got out of the prostate but you can't find it, what stage is that? 2?
No, if it has left the prostate, it is stage 3 or 4, or T3,
But
T4.
you say you have to be able to find it.
Well, fair enough. I mean, the argument would be there is no argument. If they can't find it, then who knows you have it?
Well, because you've got a PSA reading.
Yeah, but again, the PSA does not mean that you have cancer. If you have a positive PSA, does that mean you have cancer?
Well, I don't know.
No, it doesn't. So if we refer back to previous slide.
Okay, so
yeah.
you've had the prostate removed because you knew there was cancer in the prostate.
So, sorry.
The prostate
Yeah.
is removed,
Yeah.
and you've got a Gleason score of 7, and they've done
Sure.
they've done they've done the biopsy, and you've got all the results from that.
So the biopsy, I'm assuming, was done before the prostate was removed. So the prostate has been removed.
Removed, you have
Right.
the results of the lab results of the prostate,
Right.
and they confirm the biopsy. Basically, they confirm a Gleason 7.
Okay.
So you've got it rid of your body.
Okay.
It's not in there. Lymph nodes are fine,
Right.
but you've still got a PSA.
Right.
And you're saying to me, how do you know?
No,
that
that's
cancer?
a different situation. Because
And I asked you what stage.
yeah. Okay. So what your question? I misinterpreted your question. What my assumption of your question was that you haven't had the prostate removed yet. You have not been diagnosed with cancer yet. Now we've done the biopsy. Now you've been diagnosed. Now we're going to stage it, and then we're going to talk about treatment. Yours is a different situation. You're talking about recurrence. Okay? So we'll move on to recurrence in a sec. This is different.
This is before. any
This is
treatment.
before treatment.
Sure. Sorry.
It's
Thank you
okay.
for the clarification.
Any other questions? Okay. Sorry, I lost my cursor again. There it is. Okay. So we've gone ahead and staged it. What type of treatments are available? So treatment planning needs to incorporate the history of the disease, the risk of progression, because a lot of these cancers are never going to threaten your life or your quality of life. And we're going to talk about that. I don't want to spend too much time on risk stratification, but basically they take into effect the stage of disease, the Gleason score, the extent of prostate involvement, your age, overall health and comorbidities, symptoms, and most importantly, your own personal preference as to how you, as patients, the commanders of your own health, want to guide your treatment, okay? So, simply put, when prostate cancer is confined to the prostate, generally they'll recommend one of 3 types of treatment. They're either going to cut it out, they're either going to radiate it using external beam or brachytherapy, or they're going to do what's called active surveillance. So there's members here from the active surveillance group, is that correct? Okay. So I just want to spend a couple minutes talking about active surveillance and how our role as physicians come into this. Active surveillance used to have the name of watch and wait, but that's not what I consider active surveillance. Watching and waiting is passive. Active surveillance is exactly the opposite. It's active. It means that you're going to be following up with your family physician, your urologist, on a regular basis. Some of our patients will follow up monthly, some every 3 months, some even more often than that, because they want to talk about symptoms. They want to talk about the anxiety that comes with active surveillance. They want to talk about what they can do in terms of lifestyle changes, or otherwise known as complementary therapies, to help their health, basically, and preventing the spread of their prostate cancer. What I also want to do is talk about the multidisciplinary team. It includes yourself, the family physician, the urologist, the oncologist, dietitians, counselors, and chronic disease nurses. So it's always considered a team. And if you don't have this team at your disposal, you need to do something about that, okay? Or talk to your family physician to get these people involved in your health care. So, does everyone see the difference between active surveillance and watching and waiting? Yeah.
Can you elaborate a little bit more about the symptom reporting? What kind of symptoms we are talking about?
Symptom reporting in detection. Symptoms in when you're doing the active surveillance? Yes. Okay, so let's go back to the lower urinary tract symptoms. Right there. Those are the symptoms that you're looking for. And one of the big things that you should notice is, and which I didn't put up there, is that it's a change in symptoms. So say, for instance, you're going to the bathroom in the middle of the night once or twice. All of a sudden, you start going 4 to 6 times a night. That should ring an alarm to say, I need to go talk to my doctor about this. If you see blood in your urine or blood in your sperm, you need to be coming, and I think that's pretty self-explanatory. But those are the symptoms, okay? The LUTS symptoms.
Just a question.
Yeah.
How are those symptoms different than a guy thinking that he's just getting older?
Yeah, okay. So again, baseline changes.
I would be getting older, and I might experience many of those things.
Right.
And yet, it wouldn't be indicative of having prostate cancer.
No, it wouldn't. But it's worth going to your family physician. Despite getting older, well, getting older isn't a medical condition. Okay, it's a natural progression of life. But if you start seeing changes from your baseline, regardless of your age, regardless of what what you might think is normal for your age group, get it checked out. Does that answer the question, Stu?
Well, I'm just thinking in my own case.
Sure.
I would have not thought some of those conditions to be any different than just getting older. Therefore, I wouldn't have brought it to your attention. If you asked me how you're feeling, I'd say, oh, yeah, I'm feeling fine.
And I think that's why one of the, which we'll talk about right at the end, is the annual physical exam. I think that's where the role of family physician really comes into play, because it's at the annual physical exam that we will probe you for these questions. Okay, we will probe you. And if I ask you, how many times do you get up in the middle of the night to urinate? And you say 4 times, I will say, we need to get some tests done. Yes?
It's also true, is it not, that you could have a developing condition of prostatitis.
Yes.
And not have prostate cancer and have many of those symptoms.
Right, absolutely. But the key is that even if you have the symptoms of prostate cancer, prostatitis, benign prostate hypertrophy, increased exercise can actually present with some of these, diabetes will present with some of these, it still needs to be checked out, right? So I guess the take-home message is, if you are having any of these symptoms or a change from baseline, or you know of anybody that is having these symptoms or a change from their baseline, get them checked out. Advise them to go see their family physician, and the probing will begin, for lack of a better term. I apologize. Okay. I'm going to keep this very close to me. Yes, yes, go ahead.
You mentioned forming a team.
Yes, sir.
Who will be take the initiative doing it? Is your family doctor or whatever? The reason I'm saying, okay, I tell you why I asked this question. Most of the time, your family doctor don't have time for you. If you say, I want to active surveillance, he just get out of my door.
Okay, you need to change your family doctor. That's the short end of it. The reason I say that is, okay, look, more and more common it is becoming known that it used to be that the family physician is going to, you know, handle all your concerns, the whole 9 yards. They're going to act like your neurologist, your cardiologist, your urologist, your radiation oncologist, your dietitian, your counselor. Nowadays, I am a firm believer in the multidisciplinary team in assisting family physicians in getting their patients and getting their health up to par, okay? It's no longer done, at least in our practice, it's no longer done by just the family physician, okay? So if your family physician doesn't start that, then you need to ask them to get a multidisciplinary team involved. You should ask for a referral to a dietitian or a counselor. If you're still having issues, then come see us. Okay? That's the short of it, folks. Everybody runs their practices different, but I can only speak to how I run mine. Any other questions? Okay, so we talked about the active surveillance. Where are we here? When prostate cancer becomes more extensive, metastatic spread or advanced, treatment options are typically radiation therapy, usually combined with, or can be combined with, hormone deprivation therapy, radical prostatectomy again with lymph node dissection, hormone deprivation therapy, chemotherapy, as well as palliative care. And typically, it's going to involve more than one modality at that stage, okay? So the next part of the talk that I want to spend a little bit of time on is, I'm going to skip that one, is the adverse effects, the complications of therapy. What do we see in our family practice? So typically in patients with who've undergone radiation therapy, whether it be brachytherapy or external beam, we see significant gastrointestinal adverse effects. So patients will come in with significant nausea, vomiting, diarrhea, abdominal pain, something that's referred to as radiation proctitis, enteritis. Has anybody ever encountered any of that, or no? Okay. So radiation proctitis, that is an inflammation of the prostate. It can be incredibly painful and is typically treated with high-dose anti-inflammatories, antibiotics at times, but can be incredibly painful. The enteritis is the inflammation of the bowel, okay, the bowel wall, which can lead to, again, significant pain, lack of absorption of certain nutrients, as well as water, and rectal bleeding, which needs definite further assessment, okay? We also have, patients will develop what's called incontinence, inability to control their bowels, basically, okay? And significant pain with bowel motions. Strong urges to have bowel motions, and incomplete evacuation are some others. The rectal bleeding, the reason I say it requires further investigation is because it can sometimes mask something else that's going on in the bowel. So you go ahead, you get your radiation done, and you develop rectal bleeding, and you think to yourself, well, that's okay because I just had radiation, so, you know, it's probably due to that. Okay, but it can also be due to a colon cancer. It can also be due to a polyp that can develop into a colon cancer. It could be due to a hemorrhoid, but it needs further investigation. Oftentimes, we do it all in the clinic. Oftentimes, it will require a GI referral or a gastroenterologist. Some of the urological side effects that we encounter include increased frequency, urgency, painful urination due to inflammation of the bladder or the urethra. Urethra is the tube that you pee out of. And the urethra can form a stricture. Okay, so I don't know if anybody's ever come across this before, but you have? Okay, so for those who haven't, a stricture is typically your urethra is a nice smooth tube. Urine goes out, then the tube collapses. And that's called a stricture. And that can be due to things that are pressing on top of it, or it could be just due to the walls collapsing. Okay? And that's usually repaired using a dilator, okay, or a Foley catheter, and that generally does the trick. Sometimes it has to be a little bit more invasive, but that's typically how it's done. Sexual dysfunction. So we're talking about erectile dysfunction. All sorts of different types of medications that are on the shelves these days, including Viagra, Cialis, Levitra. Non-pharmaceutical devices also exist. And patients have actually reported some benefits from talking to counselors. So that's another reason why a counselor needs to be involved in your care. Fatigue. One of the most common side effects, or adverse effects, I should say, of radiation therapy. So for that, I usually recommend a very active lifestyle, which is tough when you're tired, a healthy diet, ensuring your vitamins, so your vitamin D, especially if you live in this province, and your vitamin B12 are at optimal levels, as well as your iron levels, which usually tank during radiation therapy or a radical prostatectomy. So again, we would involve health management nurses, dietitians to help you get over this rut. And the feedback we get, at least in the clinic, is it's very positive. Brachytherapy, you're also going to get something that I thought was very interesting called seed migration. Has anyone heard of this? So the seeds that they implant into the prostate, imagine a kernel of rice, migrates in the body, and they actually find it in different organs. Find it as far as the lungs. They don't know what the clinical, manifestations of that are, or the clinical, what it can actually do, but they know that they found it as far as the lung. So I just thought that was interesting. Okay, let's talk about the radical prostatectomy. So open or minimally invasive, robotic or laparoscopic, those are the different types that are available. The adverse effects are actually fairly similar. The big ones include the erectile dysfunction. Now, the extent of the actual erectile dysfunction depends on the age, pre-surgery sexual function, and type of surgery that you're having. Is it nerve sparing or is it non-nerve sparing? So let's have a look at that. I don't think anybody can read that, can they? Okay, so bad slide on my behalf. What nerves you're actually talking about here are the cavernous nerves, okay? And they also control one of the sphincters, okay? It's the urethral sphincter. And when those get cut due to non-nerve sparing surgery, or because it's an actual risk of the surgery, maintaining an erection is very, very difficult at the best of times. So there's a thing called penile rehabilitation. Who's heard of this? Okay. It consists of medications, so like the Cialis, the Viagra, vacuum-style pumps, as well as more invasive techniques such as injections and implants. But even with non-nerve sparing surgery, the sensation and ability to ejaculate are actually maintained. And like I was saying, the nerves that are usually affected are the cavernous nerves. Okay, androgen deprivation therapy. Anybody heard of this? Okay. So it's used in advanced prostate cancer, usually in conjunction with other therapies. Okay, it's otherwise known as hormone deprivation therapy, and it's done via medical surgical castration. Works by eliminating the production of testosterone, which prevents the growth of the cancer. If the PSA continues to rise, it is considered castration resistant, and the need for chemotherapy usually comes into play at that stage. Okay, it can be offered as a therapy. But adverse effects of ADT are significant. Loss of lean body mass, increased body fat, and loss of muscle strength. Loss of libido, or the drive to have sex. Loss of bone mass, which can be worsened significantly with bony metastases. Has anyone had bony metastases or heard of anybody that's had it? Okay. It is incredibly painful. Okay, so there are medications that we use to counteract the leaching of the bone. Okay, it's called bisphosphonates that help preserve some of that bone and at the same time helps with some of the pain. But it is very painful. Okay, gynecomastia, so men growing boobs, loss of body hair, fatigue again, as well as significant mental health adverse effects. Patients commonly develop depression and anxiety. And there's also cardiovascular and metabolic side effects. So, monitoring disease and the role of the physician. This is kind of important because you've had your prostate cancer diagnosed, it's been treated. So who monitors it? Well, you do, and your family physician should, okay? And it's a huge role. It's a very important role. So in monitoring, that again means regular follow-up. And what we're looking for are worsening symptoms. Now, some of these symptoms can include the LUTS symptoms that we talked about earlier, bony pain, confusion, headaches, changes to vision, nausea, vomiting, type B symptoms, otherwise known as fever, night sweats, loss of weight, loss of appetite, bloody sputum, so you're spitting up blood, rectal bleeding. These are just some, to name a few, okay? This is just to name a few. But again, we're going to talk about the annual physical, where a lot of this actually comes forth, okay? We have a role in monitoring for comorbidities, okay? These are things that happen as a result of prostate cancer. You can develop heart disease. You can develop infections. You can also develop mental health issues. And one of the other most important things that we do is answer your questions regarding a Gleason score. Well, my friend had a better Gleason score than I did. What does that mean? Okay. Prognosis. We talk about active surveillance and complementary therapies. So let's talk about complementary therapy. What is it? It's used to complement what therapy your radiation oncologist, your urologist is going to have you do. It includes lifestyle modifications, diet, exercise. It may include physiotherapy. It might include occupational therapy, but it is not done in replacement of the prescribed therapy, okay? Alternative therapies, there's no actual evidence that they work, and alternative is exactly that. They're advised by infomercials, the guy down the street, maybe, who knows, but there's no evidence that they work, and certainly they should never take the place of what has been tried and tested and true, okay, that has evidence to back it up, okay. You know, and at times, you know, people get complementary and alternative therapies kind of confused. But again, like I say, complementary therapies are there to complement the radical prostatectomy, complement the radiation therapy or the androgen deprivation therapy. It might involve pain management because, again, you're complementing what is already happening, okay? Some of the things that alternative therapies that I just Googled was people claiming that if you did a cleanse, you could cure your cancer. That's not going to work. Okay? TV infomercials on prostate cancer. They exist. Watch TV at 3 a.m., you'll find them. Herbal medications. They're not going to cure your cancer. Yes, question?
Where would you put naturopathic medicine? Going to naturopath, would you put that in complementary or alternative?
It depends on what the naturopath is advising. Okay? If they're saying you can do this cleanse and your cancer is going to go away, I would tell you get out of that office and go see a physician. Okay? Any other questions?
Yes, in that case, what could they say that influences you to listen more or take their advice?
I'm not sure, because my interaction with naturopaths is 0 to none. So I'm not sure.
So you wouldn't put a naturopath on your clinical team, is what you're saying?
Nope, I didn't say that. I would need to know more about it and see what they're going to advise my patients. Because if they advise my patients that if you do this, you drink a Sprite and you're going to cure your cancer, they're going to be fired from my team very quickly. Yeah.
No, but there are a lot of other things that perhaps they could be suggesting it may be doing to you.
Perhaps.
So it's worth listening to them.
I'm never adverse to listening to them. But I will not go as far as saying that I will hire them without hearing what their strategy is.
But you're not the patients.
No, I'm not. And that's why I don't fault my patients for going to see a naturopath. You can go ahead, but do not let it take away from your actual treatment. Does that make sense?
Yeah, I can replace it.
Absolutely. Any other questions? And just one caveat to that as well. Some of the therapies, because again, if you want to call it Western medicine, okay, I don't like these terms, Western versus Eastern medicine, but we don't know how certain alternative therapies are going to interact with your prescribed therapy, okay? So, for instance, if they suggest therapy A, we're not going to know if it's going to affect your radiation. We don't know, because there's no evidence, okay? So, if you are going to do something like that, make sure you tell your treating physicians that you are doing that. Does that make sense, or is that clear as mud? Yeah? Okay. Okay. The annual physical exam. Okay, that's what the CPX stands for. It is probably, for me, one of the most important aspects of family medicine. Why? Because it is where most of your topics, your screening for chronic disease, for cancers, monitoring disease is going to happen, okay? Yes, we see our patients very regularly when we're monitoring them, but screening occurs once or twice a year, depending on your risk factors, of course. So, at the annual physical, you are screened for diabetes, high blood pressure, cancers, the prostate, breast, colorectal, lung, mental health. It's a head-to-toe examination. If you're currently in treatment for something, okay, we want to know, is it working? Do you have any adverse effects? These are all good questions, and this is a great time for you to report this to your family physician, okay? Do you feel that you need something else? Do you need somebody else involved in your care? This is a discussion worth having, okay? And 9 times out of 10, these questions come up in the annual physical. So I implore you all, make sure you attend your annual physicals if you have a family physician. If you don't, please get one, okay? As we were saying upstairs, 50 to 60% of Calgary does not have a family physician, okay? And just a little bit on the bottom here. The annual physical also, and at least this is what we do in our practice, is that it helps me develop health goals and plans for you guys as patients and involve you in those plans. As well as your families, because your health is going to impact your family's health as well. Okay? Okay, so I'm just going to give a quick spiel about my clinic. It's the Foothills Medical Clinic. It's located in the Foothills Professional Building. Like I say, we're a multidisciplinary family medical practice and walk-in. That's what we do. Prevention, early screening, early intervention, and a multidisciplinary delivery of healthcare. I guess you could say we specialize, I suppose, or we see a lot of, I should say, chronic disease management, pediatrics, women's health, seniors health, and counseling services. There's 4 of us. And we also offer dietitians, counseling, and chronic disease nurses, which is important. Like I say, it's the multidisciplinary team. I wish we had a urologist on staff, but we just don't. And that's pretty much it. So I'm more than happy to take some more questions. I just also want to just take a moment to thank you all for coming out. And I hope you found this informative. I want to say thank you to the Prostate Cancer of Canada Network of Calgary for hosting me today, as well as my wife, who's here taking pictures and is a true inspiration for me. Thank you.
Just don't run yet. Are there any further questions?
I saw one here, and then we'll go maybe.
Okay, you and grab them. Oh,
Okay.
both later?
Or-
No. Okay, take the.
Yeah, I can. Yep.
What's your views towards the use of metformin by prostate cancer patients as a method or mechanism for reducing blood sugar or glucose to try to attack cancer?
Okay. So the question is, and correct me if I'm wrong, the use of metformin to reduce blood sugar levels and weight? Not weight, just blood sugar levels? Because they have developed diabetes as a comorbidity?
No, not non-diabetic, but there's lots of research that's showing metformin as an excellent drug for prostate cancer sufferers, as a tool to use against the prostate cancer, and for many forms of cancer. What's your feeling as a physician?
I think that I certainly haven't read the evidence behind it to see whether or not it would be something that I would recommend. But if the evidence is strongly in favor of it, then I don't see why there would be any issues with it. Metformin is a commonly used medication in the treatment of diabetes, type 2 diabetes. It reduces your blood sugars. At the same time, a common side effect of metformin is that you will have weight loss as well. In the treatment of cancer, I have not seen the evidence, so I would not want to, guess as to what I would prescribe. But I would certainly look into the evidence, and if there's strong evidence for it, then absolutely. Yeah. In the back?
With regards to your team that you have, the
Yes, ma'am.
dietitians, the counseling, are they all covered by Alberta Healthcare as well?
Yes. So that's a common question we always get because, well, nothing's free in this world, is it? Okay, so yes, it is absolutely free. Yeah. A dietitian usually runs, now correct me if I'm wrong if there are dietitians in here, but I think it runs between $80 to maybe $100 an hour, somewhere around there. So I can see why, maybe perhaps you have not involved dietitians in your care before, or counselors, or the multidisciplinary team, but I certainly do believe in it. Yes?
I know a little bit about the urologists that are out there at the Foothills, but I haven't understood what the relationship is between the GPs and urologists. When you refer somebody to a urologist, how do you know which urologist you're going to refer to?
I send it to a person. I don't send it to urology at Rocky View. I send it to Dr. Duffy, Dr. Kawakami, Dr. XYZ. I send it to, okay, well, here's the thing with the urology group in Calgary. We actually have a center of excellence for urology here, okay? So all of them are, I would say, incredibly competent and knowledgeable in what they do. So I have no hesitation to send it to any one of them. And I just send it to the few that I know by name. That's it. Yeah. And what I do is rely on my patient's feedback about that certain individual. So if we get negative feedback about a certain specialist, family physician, allied healthcare worker, we certainly won't be referring patients to that individual. Yes, sir.
Oh, you have multidisciplinary team. How's the language?
Okay. It's a tough one. I speak 4 languages. That's probably not enough for Calgary. Calgary is incredibly multicultural, and I wish I had a translator or an interpreter in our clinic, but I certainly don't. What I would advise is that if you do, and that's not just for my clinic, I advise this for everywhere. If English is your second language, please bring somebody with you to all your appointments that can translate, okay? It is absolutely important, okay? So that you have a very clear understanding about your health, okay?
Second question. I heard through the grapevine saying, okay, that there's a new testing on the blood that they can substitute biopsy. True or false?
I take the 5th. I don't know. Yeah.
Last question.
Fire away.
How do you comment the statement, cancer can be cured?
Can I make that statement?
How do you comment on this statement?
Oh.
So many things on the news, on the television, whatever. So I want to ask your opinion on that.
Do I think cancer can be cured? Sure. I do. I certainly do. I think that oftentimes, you know, we see some great outcomes with our cancer patients who go on to lead tremendous lives, have no impact of quality of life. So, yeah, I do believe that cancer can be cured. Yeah.
What's the difference between PSA and PSA? I got diagnosed in 2004 with cancer, and still they have my PSA is 65. My brother, his was 0.5, and he had the full treatment. I have never had any treatments. I never had any pills. I had nothing.
So I'm not sure. Sorry, I don't understand the question.
My specialist says, "Oh, he's too invasive," you know. In the meantime, I got to be 85, you know. And then I talked to another doctor. Well, he said, "You won't get any help anymore." He said, "The government wouldn't go for it."
So if you had that patient at the age of 85,
that's right.
With only a PSA of 65.
Right. Oh, okay. So, yeah. So if I'm understanding the question correctly, it's basically saying that if I had an 85-year-old patient who has a PSA of 65, what should I do with it? Right? Is that what you're asking? Should I treat the cancer or not?
Well, I got a bone scan the other day, like for the bone, see if it was in the bones at the Foothills, and that was 2 weeks ago, and it was okay. And he said come back in October of 2015.
Yeah.
Yet my PSA is still 65.
Yeah, because the evidence will probably demonstrate, okay, now I'm not the radiation oncologist or the urologist, but what I'm assuming is that the evidence will probably demonstrate that the therapy is going to have greater risks involved with it than actually just doing the active surveillance.
And I compare it with my family.
Sure.
My son, he got a pain on Friday. He was 46 years old, and he only lived for a week. I had to go to Detroit, and he got a pain on Friday, and I flew to Detroit on Monday, and never talked to him again. You know, and he had prostate cancer at 46.
I'm sorry to hear that.
Died on the same thing. You know, my other brother died on the same thing. My other brother has it, and they've never done anything for me. Nothing.
Yeah. Like I say, that, you know, at 85 years of age, I think that active surveillance is probably a good option. You know, and again,
But I wasn't 85 in 2004.
Yeah, No, and I agree. I agree. I don't know, it's kind of tough to comment on an individual case, but I'm certainly more than happy to talk to you afterwards. Yeah. Good.
Well, thank you very much. I've got a little gift that I want to pass on. Now, what happened is when Ashesh came in the door, he came in with 2.5 or 2 3/4 people. I'm not quite sure. So, for certain, for your good wife, there is a sash, a prostate cancer sash, and then you can choose amongst a sock, a tie.
Oh, wonderful. That's actually a very nice tie. You guys got good colors.
Or maybe some cufflinks.
Oh.
So, there's your choice.
You know what? I will help myself to the tie.
Okay.
You can never have enough ties.
There you go. Thank you very much.
Thank you very much.